All right, good afternoon, everyone. We are going to go ahead and get started. Welcome to the Performance Driven Academy. We are excited to have you here for this installment of our webinar series. Today we are covering effective measurement practices. If you have not already filled out the intent to participate survey or the baseline survey because you are new to our webinar series, please fill that information out as we're starting up our intro slides here. And you should be receiving in the chat box shortly a link to where the materials for today's session are on the MCTAC website. We are bringing you this series from the Managed Care Technical Assistance Center. I am Dr. Brianna O'Connor. I'm actually the Associate Director. I apologize, that's a typo there, for CCSI Center for Collaboration and Community Health. Just quick reminders, since it's been a little while since we've had a webinar for the Performance Driven Academy, we are having some in-person events again coming up in June, and you'll receive links for those shortly, but just make sure everyone in your work group registers for those individually. Again, if this is one of your first times joining us, we did send out a second round invitation for folks, knowing that some folks didn't have a chance to register for the January start date. Just we would encourage you to catch up on the content before you jump fully into the activities from this webinar and the ones after this, because they really are intended to sort of build on one another. This webinar will be recorded. You should have received those materials not ahead of this webinar, but in the chat box, or you will any moment now. If you have any questions now or in the future, please feel free to email pda@ccsi.org. That's an email specifically for this work that we monitor pretty closely and respond to in a timely way. If you have any questions at any time, please chat into the chat box. If you click on all panelists, those of us who need to see it or need to remind me to see it will be able to, and will direct us to your comments. Very brief couple of slides on the PDA just to remind us where we're at and how we're thinking about this as a series. So this graphic, again, represents the elements that we think make up a performance-driven organization. Today we're focusing on one particular process, effective measurement practices. Certainly any of these processes or infrastructure or the culture could make up a lot more than one webinar, but that's what we're going to try to cover for you today. The way we put together the Performance Driven Academy, why we think these pieces all come together, is that we really think that once an organization goes through all of these steps, meets with their work group, creates a work plan from the materials and the tools that we provide, it really should position you to understand your cost, your quality, and your impact within the broader system of care in a far more rich way. We always are geared towards providing a lot of tools and resources that can really help support some of your efforts. So it's not just content and best practices, but it's really a tool to take home and take back to your agency and do something concrete with. We also talk about takeaways at the end of each of the webinar to help foster that as well, to give you a couple of actionable steps. Those of you that completed the baseline evaluation either previously or doing so now in April, that also will be provided back to you in a summary report that shows your improvement as long as we have the data from both your start and your end, so that you can see what you kind of learned from this in a quantifiable way. That's us sort of practicing what we preach around using data to understand the impact of our services. So just to summarize, again, it's been a little while since we've had a webinar, though we did have our in-person events at the end of March across the state. We have talked about how to develop a culture that really supports this performance-driven work and really prioritizes data-driven decision-making. We've also talked about some methods and mechanisms for effective collaboration, knowing that that's a key to success in our emerging healthcare environment and as the changes roll out, and also just optimizing impact for the individuals that we serve. We've also talked about best practices in the area of human resources and how to really maximize those folks that are providing the backbone of our human services, and heighten accountability for performance in a supportive, data-driven way. Where we're going now in our little roadmap here is today we're talking about effective measurement practices. We'll take that information into the next webinar where we talk about how to make action on some of those pieces of information, things we measure, how do you engage in continuous quality improvement around some of this data. and that will lead naturally into using data to really understand how to develop your practice and manage practice development. That will then be, those 3 topics will be covered in more detail in the in-person sessions in June, and really kind of tie these 6 webinars together and the concept for these 6 webinars together. Semester 2 will immediately start in July and follow the same sort of pattern of 3 webinars and in-person events, and we'll cover topics including finance and sort of the leadership to drive this work forward. Today, we are talking about effective measurement practices. As I mentioned, I'm Dr. Brianna O'Connor, and my appropriate title listed there. I'm the Associate Director of CCSI's Center for Collaboration in Community Health. We are the upstate partner for MCTAC, and we're very excited to be hosting and pulling together all of the expert resources and tools for this series. A little background about me, just so you know why I am talking about some of this. I do have a background in clinical psychology, so I have quite a bit of experience in the behavioral health field, particularly around children. So some of my examples are couched in my experience there. But I've also had quite a passion, quite a focus on the data that drives how we provide mental health and behavioral health services, how to employ research methodologies and statistical analysis that really help real-world behavioral health settings engage in effective, meaningful performance measurement. Today's learning objectives, I think the first one is probably the most critical for you to understand. I plan to provide way too much information for one webinar, and I sort of apologize for that if it becomes too much, but I also really like to pack in as much as possible because I know there are folks on a wide spectrum of readiness and motivation for certain areas of this, and so I want to make sure that everyone has a little something that they learn from this and something that they can take from this. I will start with defining measurement and its value to an organization really briefly. Throughout the webinar, there are some tips for measurement best practices and ideas to consider as you're moving forward. There are some examples in here for how to really provide productive information that you can get from readily available data that's easy to access from most organizations. At least some component of it is pretty easy to access. I will have some examples towards the end about how to move beyond the basics. I know we've gotten some feedback from some of you that some of our content is perhaps a little bit more basic, and so agencies who are a little bit more advanced in their infrastructure and their resources that they've been able to put into some of these processes may already, be sort of comfortable with the content. So I've added some sort of advanced topics at the end of this to help focus on what those organizations need from this experience. I have a series of tools to introduce to you to support some of this measurement work, and then at the end, like always, we're very excited to have a provider with us to describe their approach to measurement and their thoughts on this topic. If it sounds like a lot to cover in the 50 minutes remaining, I did warn you with that first bullet that I plan to provide a lot of information. First, I'd like to talk about what I mean by measurement, and I know everyone here certainly understands what measures are in this world. That's why you're part of the performance-driven organization, but I like to level set about what I'm referring to. In my experience, a lot of these different terms, outcomes, measures, performance indicators, quality indicators, whatever we're talking about, pay for performance, pay for reporting, I think of those all as measures. When we add in some of the other pieces, it gets a little word soup. There's QAR, there's HEDIS, there's value-based payment quality measures, there's a series of other measures, there's DSRIP. So it's a lot of different components, a lot of different terminologies that are overlapping, sometimes meaning the same thing, sometimes not, usually referring to the same kind of constructs. To speak simply, when I'm talking about measures, I'm really just referring to a measure as something that is using data to understand something, a process, a comparison, an outcome, something like that. Data, when I'm referring to data, I'm most often referring to discrete data or numbers, so versus text or kind of clinical notes. I don't really consider that data because you can't do anything with it. It's information, it's numbers that are collected systematically in some way, and ideally we're talking about electronically stored information. Although if you have data that you think would be meaningful in paper copies of something, certainly I would encourage, if that's an area of focus for you, to move that into even something as simple as an Excel database, because then it is electronic. All of this really gets at the value proposition that underlies most of what New York State is working on right now, which is that the value of a service, the value of behavioral health as a field, represents the understanding of quality and cost. Cost is a really important component that we will be talking about more in semester 2. So what I will stick with is mostly the quality component and some of those more basic pieces of information. It certainly sometimes seems like a lot of the examples and the content that I will talk about might be too simple, especially for organizations who feel like they have a good handle on their data, but it's intentional, and it's not meant to say that there aren't certainly expert agencies out there doing some really cool things with a lot of information, but it's really about limited resources, and the fact that I don't, in my experience working with behavioral health providers, I really don't think that high-level analytics are necessary or a great use of resources, because simple data, simple dashboard views, simple visualizations, simple processes, answering simple questions can be incredibly impactful for an organization. And so I do intentionally stick with kind of simple, because I think there's a lot that can be gained from looking at the simple data. And I'll show you some of that as we move through the presentation. Also, when talking about measurement and how that can benefit your organization, there's multiple buckets of measurement. There might be more than this, but these are the big ones to think about. Obviously, financial measures on the right is an important piece. It's a whole part of the semester 2, so I won't be touching on those here. But there are also measures related to processes, whether how fast folks get in your door, what the supervision structure is like, all those kind of process pieces, how someone refers in or out of your service. There are staff variables, so there are information around staff productivity, staff training, staff capacity that can also be measured. And then there's what people typically think of when they think about measurement, which is outcomes or clinical progress. I do have a bit of a pet peeve with outcomes as the terminology that everyone uses, because most of what we're trying to measure by the HEDIS federal measures, the state VBP measures, they're actually more often process measures just by virtue of where we're at in our healthcare system. For example, when we look at measuring someone's A1C levels or measuring their screening for depression, those aren't, is this person getting more well? They are we doing good quality care that should lead to them getting more well? So I think outcomes is perhaps a loaded term, which is why I like to think of it instead as more clinical progress. Within these buckets, starting with any one of them can really help bring quite a bit of value to your organization. If you are looking at process measures, you can understand where you might need to streamline a process or become more efficient, which helps your bottom line and also improves your ability to get clients into quality care. Focusing on measures that are meaningful to your staff or helpful in their work can also really help enhance staff buy-in. Naturally, thinking about clinical progress and some of these things should lead to an improvement in quality of care and, of course, your bottom line. Thinking about measurement also and where to focus your attention for measurement is also really critical when in the value-based payment environment that we're all jumping into. Really, it's going to become important for behavioral health providers to market their services and say, this is what we do well, here's the data behind it, and here's why you want me in your VBP arrangement, here's why I bring this important piece to our network and our collaborative efforts. Again, this is another mention of how we really do listen to the feedback that folks provide us from webinar to webinar. We have heard from a couple different scenarios that folks really are worried about all of this world of performance-driven academy content really can represent something that staff might struggle with, that adding an accountability component or an evaluative component to some of the work can affect staff buy-in for the work, or adding what is perceived as additional work for the staff. So I will be focusing throughout my examples on where there are opportunities to really use measurement to actually enhance staff buy-in. So the way I've set up the rest of this webinar is a little purple title slide here with my kind of best practice advice and then some thoughts behind it. So my first suggestion, my first area of focus is to really think about with measurement, as we are working through performance-driven organization components, it can seem like a daunting task. There's a lot of different information that you could collect, that you could look at. You could look at staff accountability, you could look at this or that, and my first primary piece of advice is just to get started. Certainly do it thoughtfully, but just get started. I think about measurement, whether it is something you've been doing or is new to you, as a new skill, and especially streamlining or making your measurement efforts more effective can be a new skill. I think a lot in analogies, so I found a couple of images in Google to help support that. So thinking of measurement as something like beginning a new physical therapy or exercise regimen, or when we're working with patients in the mental health side, teaching someone how to change the way they think in a cognitive behavioral therapy approach, setting up a routine with your kids. These are all new skills that on the surface seem very logical and rational, and of course we can all think through how to set up a routine outside of someone's symptoms. Filling out a thought record is quite straightforward and makes perfect sense. We all know that we should exercise, probably more than many of us do. We know these things logically. It's actually integrating them within our daily life in a way that is meaningful that is the challenge. And the same is true for measurement. I'm certain that everyone on this call knows that if they had unlimited resources, they know what they could measure, how they could measure it, to know that what they are doing for the individuals they serve. It's the practical part that can sometimes get in the way. So thinking about measurement and just getting started with something, just start with something. The first piece of advice to think about is that perfect is really the enemy of good for measurement. I've heard a lot of times folks say that I don't have the right data, I really want to answer this question, but the data's not quite there, and so they'll try to wait for the data to be there, or there to be more data or better data, and they're going to be waiting forever, truly. That there's never going to be perfect data for measuring things such as behavioral health, which are pretty changeable. That said, even though you're just going to get started, it's important to know that there is limitations. There are limitations to all data that you could possibly have, even if you found what you thought was the perfect data. But it's important not to get hung up on them, because understanding what they are, clarifying what they are, being transparent about what they are is sufficient, because at least you're trying to learn something. I mentioned trying to make it as part of the routine, so and I'll come back to this point in a few different ways, that really the more your measurement efforts can be targeted to something that is an important part of your clinical workflow, or some part of the routine that your staff and your agency completes, it can really enhance the work being done, enhance the outcomes, and also make the lift, the burden of additional measurement or additional processes seem much smaller. High-quality measurement, effective measurement, as simple as it is, as rational as it seems, like setting up the daily routine checklist for a 3-year-old, it really does require practice for it to become second nature, for it to become integrated and easy to see and operationalize. Like most behavior change, you know, we're in behavioral health. I think everyone, again, probably knows this too, but just to state it here, you want to start easy. We know that early success leads to continued efforts on any behavior change. Anyone who's ever tried to, you know, change how they eat or exercise or any other routine, you need to see an early win to really want to motivate yourself to continue doing it. And the same is true for your staff and for measurement practices. So I often get the question, though, but where do we start? Or from organizations who've been doing some of this data, we need to re-energize our efforts. We've been collecting data, we look at this and this, but we're not moving the dial on it. What do we do? And for this, I think that what's best is to start with what you're good at. And this is also really great for that staff buy-in, because staff generally are in this area, they're in your agency because they like helping people. And so if you get them energized around what are you doing for folks, what's the benefit of what we do, how are they getting better, what outcomes are you most proud of, that can really energize the conversation and identify some targets for what you could measure to show, actually, yeah, we really are doing this across the board for a number of different types of individuals. So these are some sample questions there's a Brainstorming Impact tool in your materials, and I'll show you a little bit of it later as well. But really the goal is to just start thinking about, with your work group, what do you do well? What's the impact of your service? How do you know? And what would be the alternatives if the service didn't exist? Because that can often really give you an idea of where you fit in the broader system of care, where you fit in your community, in your network. It's also really important to think about what information is actionable, preferably soon. So what information is immediately actionable and is meaningful? And again, just like any habit that any of us are ever trying to start or our clients are trying to start, you want to see early change. You want to pick something to measure that is likely to show change sooner rather than later, that you're able to have some actionable steps to take sooner rather than later. So the comparison I put here is the line graph there is a really important target for our system as a whole and for your agency, which is reducing the rate of potentially preventable ED visits. We all need to focus on that. This is all simulated data, just to show as an example. However, that's really hard for staff to get motivated behind, especially in a larger agency or even in a smaller agency. I only have control over, clients in my office. I can't control what they do when they leave. I can't control my colleagues' clients. I can't control any of that. So it's hard for me to get excited about what I can do to change the direction of that line. However, one of the VBP quality measures is mental health engagement and care within 30 days. And just looking at that information a little bit differently, you can see that there is some way that I can get motivated as a clinician if we're looking at it more closely. So we're looking at these couple of months, not what happened 3 years ago, and we're looking at something I can change. I can affect my ability to engage someone, my ability to work through the assessment phase real quickly so that we can get to a therapeutic visit within the first 30 days. Working with my clinical team, of course, we can restructure the way we do our assessments so that there's a therapeutic visit sooner in the process. And providing some comparison across clinical teams, not meant to unnecessarily foster competitive feelings or be evaluative, but is also just meant to be a bit of a benchmark of how you're doing. There might be something qualitatively different about clinical team C. Maybe it's smaller, maybe their wait list was longer, they serve a different population. It doesn't mean they're not doing a great job, and they're actually probably increasing the most on that trajectory. It's just, again, a way to sort of energize folks around something they can do differently. And we talked about this in the Human Resources webinar as well, but it's also really important to celebrate those successes for folks, particularly given one of our other suggestions from that content area, the Human Resources content area that we talked about in the in-person events, which is the importance of tying staff performance appraisals to objective measurable data. And so one of the examples that we shared was that you could hold your staff accountable for reaching a certain rate of show rates, of client engagement and attendance. And if you're going to do that, then that's the measure that you want to focus on, and that's what you want to energize folks around so that they all kind of tie together. So the next important piece to think about, so you're going to get started, you're going to look at some data that's meaningful, that's actionable. Now the question is, what are you going to look at? So what question are you trying to answer with your data? Which is another kind of personal pet peeve is why I cringe when people say, well, what does the data show? Because my response is always about what? What question are you trying to answer? And so here are some tips for how to streamline that. Again, in behavioral health, I think we are actually at quite an advantage for doing some of this work as opposed to other professions, other areas of business, because we already have to do all these things to provide good care. So we all know about SMART objectives, whether you know the acronym or not. When we're writing treatment plan objectives, we have to use specific, measurable, achievable, relevant, and time-limited goals. The same is true for agency-wide measures. It's really important to be specific about the who, what, when, where, and why of what you're measuring, being careful not to use jargon or ambiguous language that will be difficult to understand or interpret later. It needs to be a measurable measure, so you need to know how are you going to know when you've met that goal, what data are we going to use to track our progress on this. Of course, it has to be achievable within reach. If, in the previous example, if you were looking at engagement and one team's rate was 22%, you wouldn't say by next month I need that to be 98%. That's not achievable, and it's probably not all that reasonable. It's important that whatever you choose to measure is relevant, so it's meaningful to the organization, but also to staff, again, to enhance their buy-in. It's got to be something they can see the value of as well, and also relevant to the bigger picture, to that value-based environment, to managed care companies, to your network of providers. I have an example for that in a moment as well. Measures should also be time limited, much like our treatment goals in our service. If we're working on the same goal with the same client for a long period of time, depending on the presenting issue, probably we didn't hit the mark on the goal or the intervention. So the same will be true here for the measures. When are you going to review your progress on this measure? When would we expect change? When are we going to know we have to do something differently or look at something differently? So here's just a couple of examples of a good idea, something to measure on the left, and then a better way to write that measure that is more specific, more measurable, meets that SMART criteria a little bit better. It's not best or ideal because I'm certain within your agency or even just thinking about these, there are better ways even than what's here. But just as an example, access to services is an area that everyone is very motivated around because we know folks can't get more well, they can't move along in their recovery if they're not in the services that can support them by and large. So improving access to care is a great idea, but it's hard to measure. A better way to measure that would be those examples there. So perhaps families who initiate contact are given an appointment within 2 weeks. You can measure that. You can look at how long it is between when someone contacts your agency, when they're given an appointment, and calculate what % of those families have one within 2 weeks. Similarly, you can track whether 75% of your referrals are contacted within 48 hours of receipt. You can look at that. The same is true for the other examples there, and you have access to the slides, so I won't go into detail with them. But what you'll see is that the numbers aren't 100%. That's not the goal for most of them, unless they're kind of low-hanging fruit. They're not even that high. They're very specific, and the better measures column is something that if you gave that to everyone within your work group and you gave the data behind it to everyone within your work group, you would probably all calculate the same number, the same final measure, and that's what you look for in a well-written measure as well. There's no ambiguity to is it yes, is it no. So another set of best practices to think about is how to focus and prioritize your measurement efforts. Certainly within the performance-driven organization, as I mentioned, there are probably 100 different things that you could measure, could look at, could use data to drive decision-making on. And that would be overwhelming and probably very difficult for current providers. Meaning if you don't have, a grant of multiple millions of dollars to do that and nothing else. So instead you want to focus, you want to prioritize what you're going to measure. One way to do that is to think about, so if you did the brainstorming activity, you kind of thought about what impact does our service have on folks? What is that question that we're going to ask the data to answer for us, that very specific question that meets the SMART criteria? How does that fit within those big picture goals, the state's goals, VBP, MCO priorities? How does it fit? One tool for doing that is to draw it out in a path model, logic model, whatever makes sense. So you can do that by starting on the right there, so you can list out what is the state goal, what is the quality measure, and then kind of work backwards. What are the steps that would lead to that? How would that occur? How would you know? How would that get all the way back to what we do? And then on the left you have, what is it that you do well? What's your impact? What services do we provide? And then as you walk it forward, does that make sense? How do we contribute to that end goal through our services? This busy slide is an example of it. Again, since you have a copy of it, I'm not going to go through it, but I just did want to show you what that could look like. So for example, I'll walk through just a small piece of it to give you the idea. If you start on the right, where the state goal, which we're all well aware of, is to reduce avoidable ER and inpatient use, one way that you could do that, how would you do that on the top path, is you'd need to reduce crises among your population. That makes some sense. How do you reduce crises? One of two ways that this model shows. You could make sure that there's access to mobile crisis services, and also the service you provide could support de-escalation strategies. Following that path, how do you do that? How do you support de-escalation strategies? One way would be to make sure that family self-management wellness tools are taught to the families that support these individuals, that you're providing education about relapse prevention and identifying triggers. Those are things that you can measure. So you can look at your clinical documentation, or you can ask your providers, your supervisors to fill out a rating, but you can say what % of our patients that meet some criteria for crisis, what % of them are we teaching family self-management wellness tools? what % are we providing education about relapse prevention triggers? Because then we can say that because we provide this education and these tools, we are therefore supporting the use of de-escalation strategies, therefore reducing crises, therefore contributing to the big picture goals of reducing avoidable ER and inpatient use. So it's just a way to think about what you do and how it fits into the bigger picture. It certainly takes a lot of time and brainstorming activity, and it's not how everyone's brain works, but it is a model that I like to share as how we sometimes think about when a service provider comes to us and says, help me figure out what to measure, how I fit in the big picture. This is what we'll do, and it's certainly something that you can do, and as long as you have a table full of experts in your work group about your services, I'm sure it'll be a much more rich example than this one. So that's about how to couch what you do in the big picture, but it's also really important to prioritize and focus on just a few things at a time. I often get a lot of pushback when I'm telling folks that I really only suggest that you measure really like 2 or 3 things at any one time. And there's a good reason for that. It doesn't mean that you don't collect other data if you need it for other things, or if you have to, or you're required to report it. But the example there in the picture is, if you're collecting lots of data because that's what you think is going to help you answer questions, it really has the opposite effect most often, where you can't figure out what the data is showing if you have a lot of different types of things. You're looking at a lot of different measures, different outcomes. It's hard to see what story the data is telling. So if you focus on just a few measures in the beginning, you can really, again, figure out how to build that routine, start practicing measurement in a way that is manageable. It's a smaller bite to chew. Thinking about how to prioritize measurement efforts also can help enhance that buy-in, particularly if you ask folks, where should we start? What would be helpful to you if we, as an agency were to measure something, what would you suggest that we measure? And also get consumer feedback. What are we doing for you? What's helpful? What should we be looking at? And they can really offer some ideas for where to target your efforts in the beginning. Prioritizing efforts to only a few measures also really helps your staff understand that you're not trying to overwhelm them with measuring every little thing about everything that they do and everything that their clients do, but you're really focusing on a priority area or a key area of interest. So this section is really about mastering the basics. So everyone has access to some really basic data in some way, shape, or form. And it's really about making the most of that information first. It doesn't mean that you can't add more complex content. You can't add additional pieces of information if you already collect something cooler, more analytically fun. That's great if you're able to do that. But I think after doing this work for a while, and my colleagues that contribute to this have done this work for quite a while, I don't think that we've ever come across an agency that is doing an A+ job mastering the basics of their data before they move on to the more complicated stuff, which means there's a missed opportunity to really get the most out of what you're already doing and make the most of that limited resource of your time and efforts. So this section is set up to really walk through these couple of areas. So thinking about readily available data. Who is served? How are they served? How well are they served? And then what's the cost of serving them? This really helps you understand the basic characteristics of your population. Which services are you providing to whom? Are folks making progress in the right way? What impact are we having? Can we show that? And then the cost piece, it'll be in semester 2, will really be about, are you effectively using your resources in support of that mission and that impact? To support this work, there's a dashboard tool that I'll show you at the end as well. It's a version 1. It's something that we created for the overview of performance-driven organization a long time ago being last June, I think. But it's there for you if it's helpful to you now. We are planning in the next couple of sessions through the end of semester 1 to provide an upgraded version of that tool that we'll get into a little bit more detail, but it's there for you now. This is one of the areas where I have too much information to go into, but you have the slides. So what I want to draw your attention to is just some of the simple types of questions that you can answer that can really help provide actionable steps in these areas. So For example, in the demographic area, just by knowing your patient population's racial distribution and pulling some easy-to-find census data, you can see whether there are disparities. So on the left, you can see within your agency, your African-American population is kind of a small piece, maybe 15%, but then in your community, it's actually closer to about 25%. So what does that mean for you? Why is there that disparity? Why aren't African-American folks in your services? What can you do differently to reduce that disparity? You can also look at whether you're using a lot of the information you collect. So this is another one of my talking points. If you're collecting information that no one's doing anything with, it's a waste of time. So if on your intake forms you have a trauma history screener, are you doing anything with that? Are you looking to see, hey, 60% of those clients that are filling this out have a trauma history? Are we trauma informed? Can we look at that? If we crosswalk that with their presenting concerns or diagnoses in a mental health situation, there's no PTSD diagnoses. Is that appropriate, or are we missing an opportunity there? Here's another list of questions that you could answer with some basic demographic data that might help provide additional actionable steps. So we talked about some of those disparities or differences in groups of folks, but then also thinking about what else do we know about unmet needs in the social determinants of health area. Do we know about these things? Do we ask about these things? Do we effectively link patients with services to meet these needs so that we're approaching their holistic health in a more effective way? You can also think about how folks are served. So this is your utilization data, which services people are receiving. And it helps you understand how that's distributed across your population, and then also some questions about your staff use of those services. For example, basic utilization data, just looking at the types of sessions and the age of client, and we'll assume this is specifically for our ADHD population. The evidence-based practice is parent training for children with ADHD. And so I don't have to get into the notes and see what my clinicians are doing. I can look at the surface level at a pivot table of age by type of session for my ADHD population and see that I have a problem because most of my young children are going to group sessions and aren't getting very many family sessions. So that means that they're not getting the evidence-based best practice that will most improve them and be most effective for them as a whole. I can use similar types of data, just looking at what kinds of services we're providing by which diagnoses, and see whether we're engaging patients quickly. Are we engaging difficult to engage patients quickly enough? And am I balancing my caseload effectively for my staff? So as a generalization, folks with bipolar disorder, chronic disorder, really need therapeutic intervention. An assessment and a referral is usually insufficient unless my clinic's not set up to handle those types of needs. They may be a more difficult to engage population, so the fact that they're only receiving an assessment so far and I don't see an assessment and a counseling session quickly together for the majority of the folks that are being seen is a concern to me. From a staff supervision perspective, I might also be thinking that it looks like if this is one person's caseload, I have a problem here because they have a lot of assessments. That can be tough on staff and does not make for the most satisfied, productive staff. And then it's also just another example to show how to compare some results across completely made-up fake staff. So these are rates of no-show, cancellation by provider or patient, or session attended. And here I can see some breakdowns that might be of interest to me. I might want to know what's going on with some of these patterns. If I see that, in general, these orange sections for Clark Kent, Oprah Winfrey, Peter Parker, and Kim Kardashian are a little bit too high for me. Why is my provider canceling sessions? I want to look at that, and I want to find out why Lois Lane has been more successful on not having to cancel her sessions. Here again are some other questions that you could answer with simple utilization data. Is your staff trained appropriately? Are we using best practices? How do our productivity targets look? Do we have the right staff utilization, or staff distribution, excuse me? And then are some of my services under or overutilized? So you can look at how many clients are receiving a certain number of visits in a certain period of time. The last piece that we'll talk about today is really how well are these folks served. And here is where you would put in your client or consumer satisfaction information, you'd look at access and engagement, and you'd look at progress on goals. Progress that needs to be a yes/no is not a good measure because if your goal is in a substance use setting, for example, abstinence, stopping use of a substance, that is the ultimate goal, but it's not a great goal to measure because the answer will be 0, no, all the way until it's a yes, which can really impact client motivation, staff motivation, and not get a true sense for what progress an individual is making towards a bigger goal. So here again, just looking at goals summarized by significantly improved to significantly worsened, what can you learn if you were to do that on a regular basis and not wait until discharge? And here you might see, surprisingly, 40% of our current clients in our substance use treatment programs in the first 3 months of treatment are actually getting worse or not improving. So let's drill in and figure out what we can do with that. Here are some other questions. Again, you have the slides so you can see some other questions that you can answer with just basic clinical progress data that you probably already have access to. So as promised, a couple slides just about moving beyond the basics. It's actually using a lot of the same types of data. You're just going to ask a little bit more complicated question. So I get a lot of questions also about how do we do predictive analytics? How do I know who's going to need this service, who's going to hit the ED a lot before they are? And to that I often say that these complex questions don't actually need a high-level analyst. Certainly predictive analytics is a high-level construct, but you don't need to do it because you really already know the answer in many cases to who's going to have a not great outcome if I don't do something differently. You know that either through the empirical literature about that population and their needs, state reports and other benchmarks, and your own clinical experience. You generally know what characteristics someone has that is going to be more or less successful within your services. So I would say based on that, start to stratify that outcome of interest by those patterns that you might be thinking lead to something different. Pivot tables in Excel are a very easy way to do that. Start looking at differences based on multiple characteristics. So not just how does our patient population do on this particular outcome or clinical progress, but how does that differ for women versus men of different age groups across different races. So now you're talking about the same data, you're just looking at it in a more detailed way in terms of multiple different categories instead of just one major cut. Some other more complicated questions that you can answer, again, with much of the same data, is what can you learn from those outliers? So those people on whatever your variable of interest that you're looking at that are just very different, whether it's high or low, than the majority of other folks. Do you have a lot of them? What's different about them? MCOs and value-based arrangements are also starting to become quite interested in defining an episode of care. Can you do that with your data? Can you say this is when someone comes in, this is when they leave for this particular episode of care? Can you stratify whether folks are attending multiple services and have different outcomes based on their service pattern? And then making sure to set up meaningful comparisons is sort of a next level question. If you don't have comparisons for your measures, in the beginning, that's fine, you're getting used to how to measure and what it shows, but over time you want to have a comparison because otherwise it's like holding up one hand and saying, I caught a fish this big. It doesn't really mean anything if you don't know what the other hand is doing. So thinking about what those meaningful comparisons might be is another one of those kind of next level questions. Okay, my last section before I turn it over to our partner agency is really just about breaking bad habits. And I use pictures for most of it. So this would be thinking about data that isn't actionable or required. If it's not actionable but it is required, you're stuck and I'm sorry. It's a waste of your time and resources if you don't do something with it. So if once a year at your annual staff meeting or board meeting you do a show and tell of your data but then don't do anything with that information, it's a waste of time and resources. If you make reports, even quarterly, monthly, really complex reports, and they go into a drawer or they sit on the CEO's desk and no one ever does anything with them, it's a waste. If you're thinking about what data that you can be collecting now that might be useful someday in the future, unless there's a real solid plan for that, that's going to frustrate your staff and probably be a waste of your time. So the tools that you have access to support this work, the Brainstorming Impact document, as I showed you, it's just a series of questions that guide you and having a discussion with your work group. What do we do well? How do we know? And what do we do with that information? Related to that is our data availability and use checklist. It's examples of typically available types of data and just gives you a place to summarize what do we already collect, what do we do with it, where would we want to prioritize doing something differently. That tool is pretty big and pretty complex, and we don't intend for you to fill out every single cell of it. It's really meant to guide your thinking and be as useful as you need it to be. Finally, I did mention that there are 2 dashboard templates. These are Excel workbooks where you can enter data and auto-populate pivot tables and charts and graphs based on some of the simple data we talked about around demographics, utilization, and outcomes. Those will be upgraded and updated in the next few weeks for semester 1. So if you want to take a look just to see what's there, that's great. If they're sufficient for you, by all means, they're great work. We're just going to be doing a little bit more on them in the next few weeks, but I did want to share some of the slides that I created in the pivot tables come from those, so you have access to those now. With that, I am happy to open the floor to our agency experience. Today we're pleased to welcome 2 of our partners from Rochester Regional Health who are going to introduce themselves and talk a little bit about how they've been approaching measurement for the last part of our talk.
Hi everyone, so my name is Frankie Tangretti. I am the analyst in the Behavioral Health Department for Rochester Regional Health.
And my name is Liz Schreiber. I'm the Manager of Quality for the Behavioral Health Department at Rochester Regional Health as well.
So today we're going to be talking with you about our data strategy and how we come about looking at things. We don't have a specific example for you at the moment, but that is going to be in a separate, a separate webinar that we can take a look at another time. So here you can see an overview of all of our behavioral health services at Rochester Regional Health, just to give anybody who is not familiar with us a little snapshot. I won't read all of these off to you, but right now we do have 5 hospitals total, and you can see we have 5 school-based health clinics, 14 different locations in 4 different counties. We have over 1,000 staff members just in our department that goes across all of those different counties. We have over 370,000 outpatient visits and 4,300 inpatient discharges per year about. So you can take a look at this visualization. This is our, visual. This is our data roadmap as we kind of put it together, the best way for us to start taking a look at things. So right now we are in phase 2. We're moving into phase 3 at the moment. And just so I can walk you through it, phase 1 is justification. That's where we're collecting data, we're starting some reporting. It's a very rudimentary data analysis, and there's a lot of distributed efforts. Phase 2, which we're in right now, is the measurement phase. We're standardizing everything, especially after the merge, so there's a lot of standardization that's going around. We're still defining our metrics, which seems like it should be further along than that, but a lot of times when we're re-looking at standardizing things, you have to take a step back again and redefine what you're looking at and how you want to measure. We're formulating new dashboards and working on moving into phase 3, which is our effectiveness. That's where we're looking at our KPIs. We're starting to define our process improvement metrics, and we're expanding our organizational accountability. We're also going to be looking at more sophisticated analytical tools. We do have some visualization tools at the moment, but we'll obviously be looking at how we can expand that. Phase 4 is value creation. So then you start really having insight into the data. You can make decisions based on what you're seeing. You can really start to take a look at some predictive analytics. We have talked a lot about that. We're very excited to get to that phase, obviously. Though, as I said, we're in phase 2, so we're trying not to get too far ahead of ourselves there. And the really exciting part is phase 5, and that's when you can really start to see the impact of your data. You can see your goals being achieved. You can really change processes, and you have the data to back that up, and you really, really feel supported in all of your decision making. Liz, is there anything you want to add to that?
So just to kind of give it a little bit more of a perspective of the phase we're in. So right now it's involved a lot of manual data collection. So what this looks like is having the leaders in our organization input how many slots we filled for evaluations, how many people we've seen for follow-up to hospitalization, and how many days that's taken us. So it is a very manual process, which I know for a lot of the different organizations on the phone is probably good news to hear. Our goal, of course, with Frankie's assistance is moving toward using click dashboards and more automated, as well as a lot of real-time data from our electronic medical record. And I know in the next year she's going to be doing a lot of great work to get us more toward phase 3, where we can track our key performance indicators on a daily basis.
Okay.
Rochester Regional currently has 4 different strategic areas that we focus on in behavioral health, both from a quality standpoint and from a data standpoint. First and foremost, we're always looking for our patient experience. Every quarter we collect surveys from our patients to see how we're doing. That information rolls up to our internal quality committee as well as up to the board to help inform a lot of our decision making. We also have a patient council right now that helps us to look at our facilities as well as our services to figure out ways that we can become more prepared for value-based payments. Our second strategic area is network development. We are always in the community trying to understand where the need is, where we can expand. You've probably heard of some of our great expansion in our primary care practices under Ashley Chudy, to try to really look at where is behavioral health right now, where is the need, where can we meet patients, and where can we serve them in a trauma-informed care way. Our third key strategic area is in innovation and population health. Here we try to look at the health of the region, where most of our patients are coming from, the severity of their symptoms, and that type of thing, to try to get a grasp on where our facilities should be, where we need to meet clients, and overall how we can improve the quality. Our fourth key strategic area is operational excellence and integrity. One of our goals is to always be improving ourselves. On the quality team, we really make an effort on an ongoing basis to standardize our processes across the board. As you may know, Rochester Regional Health recently merged together for the 5 different hospital systems. So part of our work is always looking to standardize and create clinical processes and procedures that are in the best care of our clients. Anything from our risk assessments all being standardized to our assessments of what level of care our patients need to be at, kind of on up. Frankie, any thoughts on that?
No, I think you covered that very nicely. Thank you for that, Liz. Does anybody? I'll let Brianna take that back over. I'm sure you have a thing for questions at the end, so I will wait there.
No, actually, that is a fine segue. That is okay. My next point of talking is, does anyone have any questions for either Frankie or Liz or myself? I have a couple of housekeeping slides just to skim through, and then while I'm doing that, please chat in your questions. And Liz and Frankie, just stay on the line for one moment and we'll get questions over to you. The last thing that we would throw out here for everyone, again, you have the slides so you can see them, is, I have a question for you, actually. We have a poll question that we want to ask you. So it's up on your chat box right now. I promise it will be done in 2 minutes here, but I know that I provided way too much information, and RRH knows that they have way too much information to share, which is why you heard Frankie say that one of the things that we'll be providing in the near future, and you'll get information about it, is a longer period of time for them to talk about what they've done around data and how they've approached measurement, because we know that having examples from fellow providers can be really helpful. So in your chat box right now is a list of what you want to know more about, and you can also chat in more options so that we can develop additional resources and tools for you. That poll will stay open for a moment. And then we are, last is a couple of takeaways. Here's what we suggested to do after this webinar. Again, please be chatting in questions. I see we have a couple coming in for you guys over at RH. But make sure you meet with your work groups to go through some of these tools. As of webinar 3, still almost 60% of folks hadn't had a chance to meet with their work groups. We really strongly encourage you to make the time to do this, because just watching webinars is probably not going to be as effective as doing the work as a group. Try to talk to your staff about what they think would be helpful to measure in their work, and then just pick a couple of areas and really just get started. Upcoming webinars and in-person events are listed there, and while you're looking at those, the questions I have for you, RRH, for folks who maybe don't know you as well, can you talk about your relationship with, are you an IPA, a BHCC? Can you talk about your responsibilities through roles there? Oh, Frankie and Liz, did we lose you?
Nope, we are still here.
So as far as I know, you guys, because you're a hospital, you're an affiliate provider for BHCCs, correct?
Yes, that is correct.
Okay. What EMR system do you have, or what analytic platforms are you using?
So we have Epic, which to our front-end staff, they know it as Care Connect. And right now, we are using, as Liz said, we even still use Excel for a lot of things, which sound, I mean, I know that probably sounds very surprising for a system of our size, but you know, if you need the answers and you need the data, then it's not as easy as you think to always get it in a more automated way. Sometimes Excel is the way to go, but we do also have ClickView, which is a data visualization software similar to Tableau or Power BI. So if anyone has worked with any of those, those are going to give you the same type of outcome.
Right. I think that is a really valuable piece of what you guys shared, is that even though most folks consider a hospital as having a lot more resources than a much smaller agency, that the measurement stuff in the behavioral health and health world really, it starts really basic and simple for all of us, that even with a larger system, Excel is a powerful tool. Manually entering the important data is really where things start for everybody, and really spending, it sounds like you spend a lot of time thinking about the process before really implementing something, so that you're careful about your use of resources.
Yeah, Brandon, that's a great point. I think most of the work is just front end, you know, very heavy on the front end. What are we measuring it for? Why are we measuring it? So just to determine that can inform our processes and our standardization.
Mm-hmm. We have one more question. I'll let you guys take a crack at it first. Someone's curious if we know of any tools or resources that can be used for some of those comparisons I was talking about, like community demographics or other things like that. Do you guys have resources that you would know about?
If you could just say the question one more time, it was cutting out.
Are you aware of any tools or resources that can be used as comparatives, so community demographics, for example?
At Rochester Regional, we find ourselves using a lot of census data to kind of help with our comparison efforts, to understand where we're at with that type, with the specific variables we're looking at.
Mm-hmm. Yeah, I think census data for community demographics is certainly one that I would suggest. Most behavioral health providers have access to psyches, which is a really great resource for state, region, county benchmark information about specific behavioral health indicators and population. And if there's that's most definitely a concrete question that we can create a tool for you that lists other data sources like that through the Performance Driven Academy. So we'll follow up with that if there's anything else that we're missing. Are there any other questions? I know we're over 1 o'clock, so if you have to leave us, we are done with content. I just want to make sure that we stick around for a moment if there are any additional questions to chat in. Doesn't look like anything is forthcoming. If you do have questions after this as you're looking at the tools or reviewing the slides, please email us at pda@ccsi.org. You'll also receive a very brief 3-question survey about how this webinar and the tools associated with it were for you, and we really appreciate all of your candid feedback. As you heard a couple times, we really think about how to respond to it quickly so that we're providing a resource that is valuable to you. We will take your poll question responses and do the same thing and see what else we need to provide to give more detail or more information for those topics you found interesting or valuable. With that, I will wish you all a good afternoon. A very big thank you to Frankie and Liz from Rochester Regional Health for sharing their perspective now and at the upcoming webinar in the future.
Thank you for having me.